Okay, we're live. We can start.
Okay. So good evening, everybody. So as we know that the Kass Talk is our one of the premier one-person talk where we hear one senior person gives his talk on his preferred topics. And we know that Dr. Maheshwari sir, Dr. Nishit Shah sir, and Dr. Devi Raja sir has been given the Kass Talk in past, but all were basically physical. But this is the due to the altered situation, we are doing this first time Kass Talk online. So, and we have a very senior faculty, Dr. Arumugam sir. So he will be giving his talk. And I would like to request Dr. Devashish Chatterjee sir to please introduce him, and then we can hear his talk and have interactions.
Right. Okay. Right. I mean, Dr. Arumugam, of course, doesn't need any introduction, to be honest. And if I give an introduction, it would be, of course, a biased introduction because I know him personally for almost 20 years. We know each other and we have been very good friends. He's an extremely dynamic organizer and a very qualified and very interested person in arthroscopy, as also in other fields of orthopedics. And we all know that he has set up a wonderful department at his college in sports medicine with wonderful state-of-art cadaver facilities, amongst his many other achievements and many other feathers in his hat. So instead of going through these formalities, I mean, he is a wonderful guy. So we'll all like to listen from him, his lectures. So I think, Oru, you should start without much talk.
Yeah. Very good evening to all the cast member, and thank you very much for kind words from my very good friend, Dr. Devashish. And I also like to thank the cast for giving this wonderful opportunity. I am Dr. Arumugam, and this is our Sports Science Center. We've been awarded India's first Center of Excellence for Football Medicine by Asian Football Confederation. So my topic of choice today is BTB ACL reconstructions. The indications for BTB ACL reconstructions are ACL insufficiency in skeletally mature individual and high performance athletes and laborers in my hand. This is our center. These are our indications. Contraindications, ACL insufficiency in adolescents, and existing patellar tendinitis and fibrous tendon and so forth. Why BTB is preferred? It has got sufficient strength, as you all know, and is ribbon-like structure as a native ACL as described by Siebold, and excellent integration of bone plug of BTB graft within the socket as confirmed by CT scan as early as 8 weeks after surgery in 80% of the patients. And this is a meta-analysis comparing the BTB with other more common the tendon hamstring. Point by point, the BTB scores over is a stronger graft, and especially Indian population, the hamstring sometimes or most often it's less than 8 millimeter in thickness. We all know the ideal size for the tendon site should be minimum 8 millimeter. Graft fixation is bone to bone is best. Cast with the interference screw is titanium interference screw is very less. Graft healing again because of bone to bone it's better. More stability, just stretching, and tunnel opening is less. The ease of revision all better. But more importantly, the graft biomechanics, all the graft, the BTB, quadruple STG, quadriceps matches the native ACL. But as we, all the clinicians, most important thing is the outcome return to sports, as published in this journal. In the BTB graft, as early as 4 months, the athletes can be returned to sports, whereas the quadruple maybe 6 months, even though standard teaching is about minimum 8 to 9 months, some special indications in career saving situations, and quadriceps limited data. And the BTB harvest is an art. We have to have a perfect bone plugs, and the tibial bone plug extension is to be harvested to minimize the graft tunnel mismatch. And the BTB graft templating makes a precision pre-op graft measurement. Routine MRI can give many measurements of exact morphology of BTB, exact measurement of effective tendon length, and the perfect prior plan. It can avoid surprises. The traditional incision increases the graft cell mobility. The 90-degree of knee flexion, midline incision definitely is going to give a graft the donor side mobility, which is quoted as the main reason for the unpopularity of the BTB graft. The also patchy numbness because of the saphenous nerve infrapatellar branch is directly over the incision where you can make. So the plan is to avoid this nerve distribution by having a safety incision and mobile window. And we can do many other way. Some authors, Philip Landru, my good friend from Petar, basically a French surgeon, you're doing a 2 incision technique. We do midline oblique or a small para-median incision. The ideal BTB harvest, the knee position should not be 90 degree, started with 30 degree of knee flexion, and 1.5 centimeter medial to the tibial prominence, 3 centimeter para-median incision, that's all you need. And subcutaneous fat is excised, create a mobile window. Paratenon should be incised, and it should be separated like this, and this should be resutured at the end that reduces the post-operative knee pain. Once you create the mobile window, knee is made into 130 degree flexion so that patellar tendon is in tension when you make the incision on the tendon. Usually take the mid 1/3 of the tendon, is about 10 millimeter, and extend the incision over the tibia. Now both the side, the incision is made. The tendon has to be tensed, otherwise there is a mismatch of fibers and the bone plug. Once you do that, you make the cut on the tibial bone and make the drill holes before harvest the bone plug so that you avoid the fracture. This is to pass the pull-through switches, make 3 so that when you fix the tibial end, you can pull hard with the tension and market the hole so that it's easy to find. Then you use the motorized saw, and the angle of the saw blade is 90 degree to this saw, and the angle to the bone is about 60 degree. And you go up to the 10 millimeter, and you have to take the tibial tongue and just use the osteotomy to deliver the bone plug. Never use with the mallet the osteotomy that links with the stress raises. Once the tibial bone plug is raised like this, then leg is made into full extension, and the mobile window is be placed on the patella. Excise the bursa, prepatellar bursa, that improves the access. And now knee in full extension. Again, make the drill hole before harvest the bone plug. Now the saw blade is parallel to the saw, and take the apex of the patella first. And same, never use the osteotome to harvest, and make sure it doesn't be the stress rises when you harvest the bone plug. So this is a tendon harvested with the tibial tongue. So we have published this in Journal of Orthopedics, about 1,200 patients, equally divided into BTB and the hamstring, and about 3 years follow-up, a minimum of 4.5 months. BTB all harvested with the mobile window technique, hamstring standard, vertical incision, and there was no major difference in the knee pain in this group. We use this mobile window technique. The other problems mostly quoted were the trans-tibial technique, which we easy to do with the BTB, will give only non-anatomical tunnels. So conventional trans-tibial technique, we all know when we started, we aim for 1 o'clock, 11 o'clock, depending upon which side of the knee. We all know the clock position is given up, and we need to have a differential tunnel is a key, and we aiming high or low footprint on the femur. So trans-tibial can be made a anatomical tunnel placement. The 3 point of optimization. One is the graft optimization. Second one is the femoral tunnel position. Third is the tibial tunnel entry. We saw how the ideal BTB graft should be harvested. More detailed steps can be found in this textbook published by Sachin Tapasvi and on my chapter we wrote. Important thing is the tibial bone plug, and we standardize the patella bone about 10 millimeter width and the tibia about 11 millimeter. And the femoral footprint, what we choose as described by Stephen Howell, equidistant. Here is 12 o'clock position, here about 8 o'clock, we make 50% on the middle surface of the lateral femoral condyle. And we mark this point through the medial portal, and we reach this through the trans-tibial technique. And the trans-tibial technique is more like a marriage. Once you made the tibial tunnel, you can't do much to change the femoral tunnel position. Choosing the entry point is important. We choose, as described by Chabra, midway between the tibial tuberosity and the middle tibial border. This almost close to the MCL and gives a good projection for the graft passage. Okay. And this is the arthroscopic view of ACL reconstruction, and this is the torn ACL. And you make the femoral footprint through the medial portal to start with. Then we drill the tibial tunnel as we normally do. Sequence of reaming with the 8 millimeter and then the 11 millimeter. The guide pin can reach where we made the pilot hole. Once we made 11 millimeter, we make the 7 millimeter trans-tibial aimer and get the same point which we made to the middle portal. Make the tibia, the zig downwards and inwards. Then we change this into the flexible reamer and go up to 25 millimeter of reaming. And flexible reamer showing how the graft will be placed. The tibial tunnel is notched for retinal wide passage so that avoiding the screw slippage. The graft is passed from the tibia into the intraarticular area onto the femur. Always mark the junction of the bone and the tendon, and use the, I prefer the metal titanium difference screw. Then fix on the tibial end and the full extension. And this is the outside picture, how we fix the screw, passing the graft and fixing the femoral screw. Need to hyperflex the knee, and whatever the extension of the bone plug can be harvested, can be excised. And BTB also can be done transportal, as you can see here. Here, first made the femoral tunnel through the middle portal as you do in a hamstring. Same steps can be repeated. Once you drill the femoral tunnel, then the tibia, as we normally do. And once you do this, you can pass the graft from tibia into the femur as shown here. Only problem is the bone plug has to be not 25 millimeter, then it will be difficult to flip the bone plug intraarticularly. Should be less than 20. That's why I prefer trans-tibial. Then use the interference screw through the middle portal. Another technique to come over to avoid the passing the graft problem is loop and loop technique. You make the tunnel on the femur there, and the tibia tunnel also made. Then you make the another guide pin, and this loop is going to the previous loop, which is into the through the middle portal. So the flipping of the bone plug is easier. And also other advantage which is important is we could do remnant preservation with the hamstring, and we can't do with the BTB. There's an example where we can do the remnant preservation also. It's an athlete who had a single bundle there. The AM is mostly intact, only PL was torn. So we used a small BTB graft, 8 millimeter and 9 millimeter on the tibia, and we were able to preserve the remnant, ACL remnant on the tibia, and the same steps we repeated and made the most of the PL bundle on the femur using the flexible reamer. So the graft is BTB graft is passed. So we are able to retain the original remnant ACL as well as augment it with the PL bundle. So this also can be done. So in conclusion, it's time to be clear the air. In 20 years of my experience, There's no cry on anti-knee pain in the BTB over the hamstring. Hamstring pain patients also get anti-knee pain. And the trans-tibial technique is anatomical. And the BTB graft, the problem is the technique, not the graft. And it's not only gold standard, also a versatile graft. Thank you for patient hearing. And we can take any questions?
Aru, can I ask you a question?
Please.
Yeah. After so many years, what is your preferred graft of choice when you are doing a primary ACL for somebody?
Yeah, my primary ACL indication is BTB, and the group of patients, like they are young, active athletes, even female patients, I do BTB. If the patient is about 40 years, then I'll go for a hamstring. In my hands, almost 60 to 65% I do BTB. Rest is hamstring, and especially adolescents, when the fight is not closed, we can do only hamstring.
In fact, that is reasonably a fair way of statement, because about 2 years ago, I think just before this corona thing, there was in the Arthroscopic journal, not the Arthroscopic, AJS, the American Journal of Sports Medicine, they published a sort of informal outcome of a study of all the sports doctors who treat the American football patients in there. And there, the incidence of patellar BPTB graft usage is very high, almost 75 or 80%. Yeah. Only around 20-25% still use hamstring. But of course, there is no valid reason anybody can give, because please remember, everybody, all grafts end of the day stretch. Whether it is BPTB or hamstring, they all stretch. Possibly hamstring stretches slightly more, but BPTB is not exempt. But yes, as Aru has rightly said, that for sports-related people, especially physical contact sports like American football, the doctors there mostly prefer BPTB, but at the same time, at least 20-25% also use hamstring. That has to be remembered also.
I think other one point is that when we now started the ACL ligament registry, I think high time we start using them. Then we can have data from our own thing. And I know Dr. Debishis also does a lot of BTB, as Dr. Kanchan Patajaya does a lot of BTB, because mainly they treat a lot of football, the soccer here, where nothing can match the BTB.
True. Well, honestly, if you ask me that, we'll talk about that later, maybe in a different scenario. I do a lot of footballers, same with Kanchanda, but here now, most of us has, for a primary graft choice, we have shifted to hamstring quite some time ago.
Okay.
We keep our BPTB as a secondary choice for a revision scenario. Even there now, peroneal longus graft is taking its precedence.
Yes. Yes.
So
any other question? Yeah, carry on.
Sir, I have Ranjit. Yes, please go ahead.
Yeah, Aru sir, I have a question.
Yes,
do you routinely go for the measurement pre-operatively, radiologically, like X-ray, MRI in all your cases?
Yeah. I think yes.
And in case of say patella alta, how you take all your precautions before the surgery?
Yeah, a good question. I routinely do, because we all patients have MRI. MRI has very good indication, and those kind of patella alta, those people, then I will measure. If not satisfactory, I'll do the hamstring.
Yeah, I mean, I have the same sort of questions. What is the usual average length of the patellar tendon?
I get with the bone plug from
the tendon itself, sir. Tendon itself, I'm asking.
Tendon itself maybe sometime 50 centimeter.
Yeah.
So the tibial bone tongue is very important. If you don't harvest the tongue, then the whole of the tibial bone plug will be outside the tibial tunnel. That's why the tibial tongue is very important.
Yeah, but that's what I'm saying. Sir. Suppose the graft is around 50 centimeter and the ACL is usually comes out to be 2.5 centimeter or something like that.
Yeah.
And then probably in the upper 2.5 centimeter of your tunnel, and only the graft is there, which is probably not snugly fitting as compared to the semi-T. So do you think that the tibial side healing is a problem in this sort of scenario?
No, usually I said 95 to 100. So 25 millimeter goes into the femur, 25 intraarticularly. My tibial tunnel length is about 40 to 45. So if I don't have the tibial tongue, then my fixation will be bad. But most of the time, I'll have entire the tibial tongue, my tibial bone plug are almost 40 to 45. Entire tibial tunnel is filled with the bone. So that is a good fixation with there. But if you don't have the tibial tongue, then what you are saying correct. Then you may have not a good fixation on the tibial side.
Yes.
Sir, how often you use bio screws on the femoral side, or you don't use?
Now, I use bio screws. Sometimes, especially a lot of people don't have the thing of stigma of metal screw. So I use bio screw. I have to make sure you pre-tap the tunnel. That is important. And then you go one size lesser. I use bio screw too, but you have to be careful. Sometimes, especially in femur, screw can break.
Okay. And what about, sir, using
in case of posterior cortical blowout, what do you suggest? Suspensory fixation is the bailout or outside in technique you prefer?
Yeah. The suspensory ligament is the best option. Also, you can do outside in. And sometimes also you can do advance the bone plug more into more proximally. Then you fix the tendon to the interference screw can be also used.
Okay.
Can I just ask something, sir? Good evening.
Yes, good evening, Gaurav.
Great to see you here.
Yes, yes.
I wish it was in person, but anyways.
Yeah.
So, couple of things, sir, I wanted to know. One is technical, the other is a bit philosophical. So the technical bit is, see, with you getting 50 mm of the tendon length, you have to keep at least 20 in the femur. I'm sure you must be keeping a 20 bone plug in the femur.
I normally use 25.
25 bone plug in the femur, 50 you have got the tunnel. So in your tibial tunnel, 25, 28 something would be occupied by the tendon in the tibial tunnel. So your tibial tunnel must be really, really long. And if you make that long a tibial tunnel, then reaching the anatomical point on the femur must be getting difficult. So what is the technical tip to do that?
No, see, normally you get about 95, 90 to 100, maximum is 100, 90 to 100, your point is right. So my tibial tunnel is about 40. I don't make it longer.
Okay.
40. But as the important thing is, I was mentioning to Sunit also, the tibial tongue extension is the key. If you don't harvest the tibial tongue, then your the tibial tunnel length mismatch is a problem.
So in your
to harvest the tibial tongue, when you're harvesting the tibial bone plug, you have to go really proximal, because the the patellar tendon does not insert on the tip of the proximal tibia. It goes beyond it. So that tongue has to be harvested when you harvest the tibial bone plug. Then that's the main tip I will give you to overcome that.
Right. So that gives you that extra bit of bone for your screw to engage in the tibial tunnel.
Yeah.
The other questions are, thank you. The other question was a bit philosophical. That is, we all know about anterior instability. We all know about the ACL, etc., etc. New thoughts have come in recently regarding the importance of posteromedial and anterolateral structures in anterior instability. So your thoughts on that, and what are the patients you select to address those structures?
Yeah, again, other one important point why BTB became unpopular is the double bundle reconstruction came about 10 years ago, which was really popularized by Freddie Fu. And that's a big change where most of us even thought of doing the middle portal reconstruction, not the trans-tibial, transportal, right? But now the studies have shown, especially the Danish registry, of the double bundle reconstructions, more revision, especially post-lateral bundle. So now the philosophical is go for a single bundle, center to center footprint reconstructions. So I don't do a double bundle ACL reconstruction. Go for a center to center and make of the AL bundle 80% of AL bundle and about 20 to 35, 20 to 30% of post-lateral bundle you reconstruct. So that is the case, then there is no need to do a two bundle reconstruction. I think double bundle ACL reconstruction is really gone out of here.
I was actually wanting to figure out your thoughts on anterolateral ligament and the importance of posteromedial capsule in controlling instability. I mean anterior instability.
Yeah, the ALL, I rarely do the ALL, especially when I do the primary with the BTB. Many people do the anterolateral ligament reconstruction and tendinosis, but not on the primary. If I do a very gross 3+ pivot on the revision cases, I may have to do the ALL reconstruction.
All right. Okay. Thank you, sir.
Thank you.
Do you have any other questions?
Yeah. Last question, Arumugan sir, because you are primarily using bone patellar tendon bone graft in all your ACL reconstruction. So what is the incidence of the anterior knee pain, for which I think there was a huge shift from bone patella to the soft semi-T tendon?
Yeah, that's exactly what we published in the Journal of Orthopedics, like we did about 1,200 patients. We did not have any significant pain on the BTB, each one at around 6%. Because a strong myth that the hamstring patient do not have anti-knee pain. They also do have. They all mainly because of the rehab. So in our hand, if we have a mobile window technique and taking precautions and harvesting and good rehab, we don't have high incidence anti-knee pain as quoted in the literature. What literature we have is Western literature. Probably with the ligament registry, we can come up with our own data in years to come.
Thank you, sir.
Okay.
Sunita, we can.
Yeah, let's. I'm sorry. We can proceed with the second talk, sir.
Yeah, let me just do that. So my second talk is on posterior instability of the shoulder, and the increasingly recognized as high as 5 to 20%. The posterior shoulder instability. Diagnosis is often delayed because of vague symptoms. Typically, it was quoted in literature 3 E's: epilepsy, electrocution, ethanol. But off late, we see excess laxity and endless microtrauma with the increasing sporting activity of our population. Here, how the mechanism of injury, direct injury onto the elbow, not out to the shoulder. And here the seizures or the violent contractions. And here the boxes on the left side, which is a decelerating injury, right? So the posterior shoulder instability can be divided into traumatic and recurrent posterior subluxations. Traumatic is direct impact, as in kabaddi, football, where the flexed adducted internal rotated arm, and also the seizure and electrocution, violent contraction of the internal rotators. We can have a reverse heel sacks and the posterior bank cut. The atraumatic could be voluntary in ligament laxity and multiple directional instability, and a chronic microtrauma, especially the throwers, swimmers, and the mixed martial arts. This is a very upcoming sports in the Asian Games. These all people have recurrent posterior subluxation leading to posterior shoulder instability. The posterior labrum, as described by Snyder, 5 sectors. The sector 6 and 5 is where we have a labral tear. The posterior tear is much less frequent than the anterior tear, as you all know. It may occur in sector 6, where it is stable because the head will hit on the acromion, so there's only pain. The sector 5 only, we have instability and give the dislocation, like here. Then the head can move downwards. Right. Comparing the anterior to posterior, anterior dislocation 90% anterior, posterior about 5 to 10%. And bone loss extensive in anterior, whereas here posteriorly is bone loss is less pronounced. Ulnar morphology is normal with anterior. In the posterior dislocation, instability, the retroversion or hyperplasia of the glenoid, and the prominent single lesion is more common in the anteriorly, and the anterior dislocation. And capsular morphology is very thick in anterior dislocation and instability, whereas posterior capsule is thin and lax. Other lesion is a recurrent post dislocation as described by Kim's, called the Kim's lesions. The recurrent subluxation leads to concealed avulsion of the post-inferior rim, as seen here. Here there is small tear, and this patient can come with more like a pain, not typical as a instability. The examination, the load and shift test increased the posterior translations, apprehension maybe plus or minus, there may be pain. The jerk test, you can check for the different sector. Sector 6 and sector 5 can pain, and the Kim's test also can be done. Investigations, light bulb sign, reverse, all rare, but typically you can see a posterior labrum tear as reverse ill sacs, as in MRI. And the ideal treatment is the posterior labral repair. You can do lateral decubitus and the portals, additional portals, and you make through the spine needle, and that's where the anchor will go in. There you can see the standard posterior labrum repair as you do the anterior labrum. Two techniques. One is the straightforward labrum. Other one is for pinch tuck when we want to reduce the capsule laxity and reduce the volume. Right. So the same steps what you do for the anterior instability you do here. The other technique, pinch tuck, basically you take a double bite on the labrum. First more of capsule, and then bunch up the capsule and the labrum, so you reduce the volume, because the posterior instability, there is a more laxity and capsule is thin as opposed to the anterior instability. And the other steps are the same as we normally do in the instability repair. The other common scenario is the labral cyst, as you can see here in the MRI. So arthroscopically, what you can see is tethering. You make a 7 o'clock portal, and then you go in there where you see this tethering and elevate the posterior labrum. Then you can see all the cyst fluid is break into. So you debride the wall. Then we go ahead, ablate the cyst wall so that no collection of the fluid. Then you go ahead and repair the labrum as we normally do, using the either we always use the indirect suture passing, that is less traumatic to the labrum rather than the direct antegrade suture passing. So in literature, about more than 50 unique publications, half of them for arthroscopic procedure, half of them were open procedure. But arthroscopy is shown to be effective and reliable for treatment of unidirectional posterior instability with the outcome scores, patient satisfaction, return to play. Using suture anchors results in fewer recurrences. And this is a study where they had 200 patients. In our study, we have about 40. Half of them are athletes. Return to sports in our population is not that good as the already published literature. So in conclusion, posterior instability is more common, can present as a shoulder pain. You have to be careful, and can present as a labral cyst. Always watch out for the telltale signs of problem. And consider lax capsule and address the same, can be managed effectively with the arthroscopy. Thank you for your patient hearing.
Yeah, thank you, sir. I think if there is any question, we can take that.
I think, of course, Aru will take questions, but the first thing, that suggestion that he made is very important, and I would like to highlight on that you have to keep looking for that, honestly.
Yes.
Unless, sorry, my video has got some, yeah. You have to actually look for it. Unless you know how to look, what you are looking for, you will not see it. In fact, initially we had it's a bit of obstinance. I remember a medical student brought his brother from North Bengal, and the gentleman distinctly said that I had a dislocation, my shoulder went posteriorly. I said, come on, did not go posteriorly, anteriorly. I was trying to push him for anterior dislocation. But then he was very quiet, but he said, sir, but it went posteriorly. And then we looked at the MRI, and it was a posterior dislocation, posterior labral tear, and everything. But the thing is, because we have a prefixed idea, most recurrent dislocation in the OPD, so that is something that we need to change, and that was a teaching that I got there almost 15 years ago, and that is very important that Oru has earmarked. Yes, the treatment is absolutely fine. Arthroscopy is very good. Open, some people have done, it's fine, but it is important to pick it up, just that.
Yeah, exactly, sir. That was my question. I just wanted to ask Rusa, that how do you pick this recurrent instability, posterior instability? Because I think those are really difficult patients probably.
They come typically with a vague pain. The posterior instability don't come with the instability,
Yeah.
There is some kind of vague symptoms.
You just have to pick up and see it on the MRI.
Yeah, I suspicion of index you must have. Because we have, when you have a pain, we always think about impingement, the abdominal pathology or cuff pathology. Just also back of mind have these posterior labrum.
Well, I have my thoughts about that, if I may share. That we know most of these recurrent instabilities are anterior. I don't want to put a percentage on that, but maybe about 98 or 99%. Rest 1% are not simple anterior traumatic dislocation. They are a mixed bag. Some are, as we all know, is a multi-directional instability sort of scenario, lax guys. There we know they may have anterior, posterior, etc. But a small subset are not typical anterior dislocation. They have some issues with the laxity or hyperlaxity of the joint, and some of them, as Oru has said, it is very difficult to confirm clinically. Although this is the test, that posterior telescoping test NIDA has recommended. I always tell my fellows to check on every anterior dislocation, and if you check, sometimes you can elicit it. That I can say. But I agree with Sunit. It is very difficult to always pick up clinically. But if you have that idea in mind, look at the MRI carefully, you can pick up. But you have to keep it in mind. The problem we had initially, we thought it did not exist. It exists only the textbook. That was personally my problem, I can tell you.
I want comment with Pabisar of Sunit that these guys probably they come with this micro instability and they are easily fatigued. That is the main complaint they usually do have. Because they don't have the classic symptom, and mostly these are classically the throwing athletes, also the people, those who are involved with the kabaddi and sort of sports where your hand is dragged and pushed and like this sort of. Easy fatigability is the earliest sign of posterior micro instability, and that is the classic of the Kimsters.
Yes, carry on.
Yes.
Sir, what was the most common symptoms in your study, in your 43 cases?
Pain, and then as Samantha mentioned, like vague symptom, tiredness, easily fatigue. They're the most common symptoms.
Right. Ranjit, I think you have some questions.
Haru sir, as you rightly mentioned, you find in some cases reverse Hill-Sachs lesions.
Yeah.
So what do you do for these kind of lesions? You leave it as such, or any indications for intervention like remplissage for the posterior heel sacs lesion. You do sometimes subscap tenodesis or like that.
Very good point, Ranjit. But as you said, as you normally you don't get such a big heel sacs. It's the MRI findings. So once you repair that, you don't have to do anything because it becomes online. But with a huge defect, as you pointed out, we can use this subscap to fill it up. But I never done that. But it's been described in the literature.
Absolutely. Same with me. I have never done it for posterior. And I have not seen, I know Oru have done much more. I have not seen two big heel sacs here as you see in the recurrent anterior dislocation.
True. Yeah. You don't get such a big bone lesion in the posterior instability.
True.
Gaurav?
Yeah, just wanted to learn something. All the posterior labral and posterior labral lesions, along with subtle instability. I haven't seen a frank posterior dislocation as we see in anterior, but I see subtle instability. And most of these have been into active sports, typically throwing athletes, and they have come with shoulder pain as the presenting complaint. It is on the MR, and with a bit of posterior labral click, do we pick them up? Now, the difficulty that I have faced with these, you've thought about it, you're going to repair something in the posterior labrum, something over there. Now, some, as these are mostly active people, their lesions may be predominantly postero-superior and a little bit posterior postero-inferior, or predominantly posterior postero-inferior and a little bit superior. So I really, when I see them, I'm at a loss to figure out which one is just a scuffing and to be left alone and which ones are to be repaired. So is there a particular zone which must be repaired pretty much all the time? Or is it that you just look at it and decide?
Well, it has to be a combined decision of the clinical symptoms and what you see on the intraoperatively, Gaurav. And as you rightly pointed out, sector 5 and 6. So sector 5 will have more of instability. There you seem to have more the defect of the labrum, where they have to be definitely repaired. And sector 6 will have more like a scuffing. You won't have much of that. But if the pain is there, then we have to repair that also.
So if you have pain, you will be, sorry. So the take-home message is that if you have symptomatic pain in a throwing athlete, you repair the scuffing as well.
Yeah. Just more like an in situ repair. Don't take much of the capsule or any typical anterior instability, the capsular shift, nothing like that, but just in situ repair.
Just stick the labrum back to where it has peeled off from.
Exactly.
Thank you, sir.
Sir, in all your cases, how often you get the full internal rotation range of movement, or there is any restriction of this internal rotation?
After the post-operatively, we don't get a restriction. They go back and do. But in our study, they're not really professional athletes. They're like weekend warriors. Some of them didn't go back to the previous level. That may be the reason why you're asking. But the committed athlete, they get full range of movement. So.
Okay. Thank you, sir.
Okay, I think there is no more question. We can proceed with your last talk, sir.
Yes, sure. Okay. So I'm going to talk on the hind foot arthroscopy. The posterior ankle problems have a typical diagnostic and therapeutic challenge. The posterolateral approach of ankle arthroscopy advocated by various authors, but it is the Nick Van Dyke in 2000. It kind of revolutionized the technique with a two-portal endoscopic approach with the patient in a prone position. The technique demonstrates excellent access to posterior ankle compartment, subtalar, as well as extra-articular structures. This is a position prone with a supportive sandbag. This is the instrument setup. Standard knee arthroscopy set what we normally need. You don't need small scopes for this kind of this technique. And also Two portals predominantly used, post-lateral portal and post-middle portal. This is a landmark. I'll tell you how to make it. And this is a post-lateral portal. Just behind the lateral malleolus, make your probe, and just middle to the Achilles tendon. And the post-middle portal is same probe is turned over and close to the tendon, make the post-middle portal. Then this is the position you do, and you can use the soft tissue distractor. We don't have to use the skeletal distraction. There are commercially available, or you can just use the stockinette and make this soft tissue distraction. And this is how you do the make the portal, patient prone position, plantar flexion 90 degree, then make the lower end of the lateral malleolus, and using the your probe, that's where make the skin incision, only skin incision, and then make exactly opposite side for the post-medial incision, again only skin, using the mosquito, go deeper. That should be directed towards the first grade toe web. That's the direction of that soft tissue dissection, and put in a scope. Then the post-medial, you put in your artery and over the scope, and slide it over the scope and bring it to the in front of the scope, then exchange into the shaver. The indications are posterior ankle impingement, then articular causes, and peroneal tendon problem, Achilles tendon problem, like retrocranial bursitis, incisional tendinopathy. The posterior ankle impingement syndrome is a collection of pathologies where characterized by posterior ankle joint pain, usually due to mechanical inflammatory conflict, aggravated by plantar flexion, repetitive load, frequently leading to the restriction of movement, common in dancers and footballers. Symptoms are pain, restriction of movement, especially plantar flexion, examination, post-lateral tenderness, and the PIMS test, the painful plantar flexion of ankle, described by Nick Van Dyke, and painful flexion of grade 2. Investigation, again, the PIM view is the lateral view of ankle, the plantar flexion on 25-degree external rotations, MRI to rule out other soft tissue, especially flexor, analysis, longus tendon pathology. Ultrasound guided injection give a diagnostic confirmation. Treatment always start with the conservative. If not, then go into arthroscopy. The causes are 80% osseous and 40% soft tissue lesions. Osseous lesions can be osteogonum, straight-up process, and loose bodies, whereas the soft tissues mainly flexor or the tenderness, the tendon, tenosynovitis, or partial tears. There's the various bony lesions, osteogonum, straight-up process, are common causes of posterior impingement, and the flexor as longus tendon pathology cause for the soft tissue lesion. The case example: 30-year-old gentleman, dancer, and footballer complained of pain and posterior aspect of ankle for 6 months, and will be treated. Examination as post-lateral aspect tenderness, restricted plantar flexion, and the posterior impingement is positive, as you can see, is withdrawing with the pain. And the X-ray showed prominence straight-up process, as shown here. So the plan is to posterior ankle arthroscopy. The steps are making the portal and clearing the soft tissue, identifying the landmarks, and then the demarking the process using the osteotome to remove the straight-up process, and the flexor osseous tendon release. In arthroscopy, you make the portals, first the artery, then the shaver is inside, and soft tissue, and some portion of the capsule is rural ligament is dissected. You don't have no issue of removing that. Then you make the subtalar joint, and here make the straight-up process using radio frequency. You can ablate the soft tissue. So demarcate this process. This has to be excised. Lack of time, I'll just forward it. So using the shaver and the bird, you kind of, after removing the osteotome, you can soften this, and this is how at the end. Then you always release the flexor osseous tendon retinaculum so that it's freely moving. You can see some kind of tendinitis, some small nodule. These are the cause of the pain. You have to make the tendon retinaculum release so that the tendon moves freely. The post-op protocol advantage is just need a cream bandage, immediate weight bearing, gradual return to the daily activities, sports as early as 8 weeks. Then peroneal tendon pathologies like this, the slipping of peroneal tendon, it can be used tendinoscopy. Here you need a small scope. What you use for a wrist, 2.7 millimeter scope, and make the distal portal just before the below the lateral malleolus. Then you can see both the peroneus brevis and peroneus longus. Then make the proximal portal the needle first. Then using the knife. Then you can deepen the groove of the peroneus tunnel, and you can fix the slipping with the suture anchor. And retrocranial bursitis Haglund lesion is a chronic problem, cause severe heel pain, can effectively manage by arthroscopy. You avoid the wound complication and the Achilles tendon takedown, and early return to the fight, the play. This is the Haglund lesion that can be arthroscopically removed. And this is the case example. Here, starting with the arthroscopy. Then you have to excision of the bursa and exposure of the calcaneus here. Using the RF to clear the soft tissue. This is a Haglund lesion. Then our technique uses two parallel wires, and above which it has to be removed. So this gives a guideline how much to resect. So then you use your bony spur and smoothen that, and use a shaver and until you see the wire which was inserted. Then you palpating the Achilles tendon insertion and scoop around small amount of the bony lesions. Then use the RF to smoothen the Achilles tendon. So you don't take the Achilles tendon out as you have to open. That's a big advantage. And once you do this, you can clearly, this is before the resection, the after resection. So arthroscopically you can remove the Haglund lesion. This is the pre-op, that's the post-op. This is Nick Van Dyck, whom I learned the technique from. In fact, his daughter, her name is Pim. That's why he named all the tests and the diagnostic test on her. Now she is actually done orthopedic residency. Hopefully, Nick Van Dyck will be coming to the Coimbatore ISCON conference in September 22. In conclusion, posterior ankle pain, history, examination, imaging study, diagnostic injection, all contribute to accurate diagnosis. Hind for arthroscopy, an excellent therapeutic tool. Return to sports and early recovery is biggest advantage. Needs better technical skills and experience to do these procedures. And it's an academic body, but I take this opportunity to request your support for my candidature as the Vice President of forthcoming election of Indian Arthroscopy Society. Thank you for your patient hearing.
Thank you, sir, for the excellent talk. I think there must be some questions. So,
Arumugam sir, after excision of your Haglund and the bony spur,
Yes,
sometimes you preferred of because there is concomitant Achilles tendinopathy also, putting an anchor and putting that part of tendon Achilles close to the bone.
well, if there is any tear or anything, I will do, but there's advantage of arthroscopy. You don't take off the tendon out, so there's no need to really put in the anchor. But I take your point. In case there is a partial tear and it is already kind of the fixation is not good, we can put in an anchor and fix it too. And the more typical Achilles tendon rupture, which happen much proximally, also there is a percutaneous technique where you can repair it without open procedure using these anchors, special anchors also by, I think, some of the companies also come up with a nice anchors where percutaneous you can repair it.
Aru sir, I think I have just one small question. Sir, in posterior ankle impingement itself is sufficient, or in MRI the tibial, suppose there is tibial process or there is an MRI reaction on those TDAS process plus the posterior ankle impingement that is more important, or just posterior ankle impingement itself is sufficient for the patient to take to the operation theater?
No, I think as any other clinical scenario, you have to do diagnostic test of injection and MRI just to rule out soft tissue process. Even though you see on the X-ray, you can pick up the slider process. But again, most often flexor Osseous tendon also affected. That's why MRI is useful. So that beforehand also you'll be prepared what to do. So I always complete the investigation of MRI. Also before taking them.
Just a technical question, sir. I've had not many, just a couple of these posterior impingements where and they were in footballers essentially. You get that pain in plantar flexion. I've taken that hypertrophic os trigonum out. Now, when I was doing it, I figured out that I had to look at the C-arm continuously to make sure that I was taking away enough and not taking away too much. Any tips on controlling that as to you take enough, but you don't take too much?
Yeah, that's a very important point, Gaurav. That's why we have the technique of putting to parallel wire before starting. Under C-arm, you put to parallel wire. That gives the guidelines. So I won't go below that. Otherwise, you never know. You may take up more of the calcaneum. So the guide wire gives the idea. So you don't have to keep shooting a C-arm.
And with the Stiders process, exactly how do you manage that? When you're taking this, when you're taking from the tailors, how do you manage that? How do you manage to do just about enough and not excessive?
In that we have to depend on C-arm.
C-arm only, right?
Yeah, just make sure you don't take too much.
Yeah, I think one point, sir, if I'm allowed to say, I mean that in Stiders process, I usually follows that where the in the upper part of the talus where the articular part finishes, and I usually cut the Stiders process at that point. That is usually the sufficient. It gives sufficient excision. The articular part and the extra-articular part junction. That is the point where you should excite.
Where you should stop.
Yeah.
So do we have any other questions?
So your soft tissue distractor was very good.
Yes.
Yeah. Then again, Nick Van Dyke's technique. So when we initially came, we didn't have that the distractor. I think that time, even now, the biometrically max. He said, no problem, give me a stock in it. I'll just use it. It's very
I think myself or Dr. Manav Basu Malik went to the Nick Van Dyke for 2 weeks.
Okay.
So he actually gifted us that the strap, similar looking strap, which the Smith and Nephew is marketing, but that's not available in India, I think.
Exactly, that's the problem. They don't market in India.
So that is a very nice Indianized version, sir.
Yeah.
So
Connect.
Yeah. Thank you, sir. So if there is no more questions, may I now request Dr. Samanta, sir, to please give a vote of thanks.
Yes, this is my excellent presentations, 3 presentations by a very dear and close friend, Dr. Mugam, and he is stalwart in the Indian Arthroscopy Society and also in the Indian orthopedic scenario in our country. He doesn't need any introduction in our field, and his contribution as a member and also the secretary and of the Indian Arthroscopy Society is tremendous. And he is teaching and he is propagating the knowledge of arthroscopy in his center and also in different labs throughout the country for many years. I know him personally for like more than 20 years. So he's always been kind whenever we are asked for coming. And last time when he requested for this Kass Talk, he immediately accepted. For the COVID, he could not meet, but he booked his ticket because last time we were there in the meeting, me and Rajiv was also there. And Ananda was also there for the last cadaver meet in his institute. So thank you, Dr. Professor Orugam, for your kind gesture and coming to our Kass Talk and grace the Kass Talk